Hello, and welcome to today's webinar, Identifying and Addressing Health-Related Social Needs Through Primary Care Innovation in Managed Care, made possible by the Commonwealth Fund. Before we get started, I'd like to go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated Q&A session following today's presentation. You may submit questions online anytime by clicking the Q&A icon located at the bottom of your screen. Today's event will be recorded. Slides and a video archive will be shared publicly on chcs.org. At the end of today's webinar, we ask that you please complete a brief evaluation that will pop up on your screen. Your feedback is very important to us. I will now turn the webinar over to Diana Crumley, Senior Program Officer at the Center for Healthcare Strategies.
Hello, and welcome to our webinar on identifying and addressing health-related social needs through primary care innovation and Medicaid managed care. So I'll start with some opening remarks, welcome and introductions. And we have two great presentations on health-related social needs initiatives from the Hawaii Department of Human Services, MedQuest Division, and the Community Health Plan of Washington. We'll follow up with a Q&A after those presentations. Next slide. So I'm Diana Crumley, Senior Program Officer at the Center for Healthcare Strategies. Over the past 4 years, I've worked with Medicaid managed care plans, state Medicaid agencies, and community-based organizations on issues relating to value-based payment, Medicaid managed care, and specifically health-related social needs and health equity. We have two great panelists, Judy Moore-Peterson. Judy is a nationally recognized leader in healthcare delivery system reform and Medicaid. Prior to working as a state Medicaid director in Hawaii, she served as state Medicaid director in Oregon and was president of the board of the National Association of Medicaid Directors. We also have Kat F.M. Latte, Director of Health System Innovation at the Community Health Plan of Washington, and that's a Medicaid managed care organization here in Washington. Kat works to ensure the plan is on the leading edge of health systems, innovation, and transformation, and is advancing health equity in the context of that work. She leads the plan's engagement and participation in major state-based reform efforts, including Washington's Medicaid transformation activities. She also manages system-level efforts to address the social determinants of health, financing approaches, including value-based payment strategy and design, and community-based programs. Thank you so much for joining us today. Next slide. So you may be new to the Center for Healthcare Strategies, and if so, welcome. We are a policy design and implementation partner dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, particularly for people served by Medicaid. Particularly relevant to our work on primary care innovation, we often provide one-on-one technical assistance to state Medicaid agencies and host learning collaboratives. So much of our work in this space is inspired by those state Medicaid agencies that we work very closely with. Next slide. This webinar is part of CHCS's Strengthening Primary Care Through Medicaid Managed Care series. The series is made possible by the Commonwealth Fund and examines tools and levers that states can use to advance comprehensive primary care. Often this is in the context of Medicaid managed care and those purchasing levers often associated with Medicaid managed care procurements and contracts. So be on the lookout for other upcoming webinars and new resources related to this topic. Next slide. Now, if you navigate to our CHCS website, it's very likely that you'll run into our toolkit for states on this subject. And that toolkit is broken up into modules and has a number of implementation considerations, state examples, and sample managed care contract language. Next slide. Now I've said primary care innovation, comprehensive primary care, advanced primary care. You might be wondering what that means to us. And the answer is it usually has 5 components: promoting health equity, enhancing team-based care, using technology to improve access, integrating behavioral health care, and identifying and addressing social needs. There are also levers to drive uptake and spread, and those are those 3 bars across the bottom here. And you also may be wondering what these check marks mean. That means that there are some great resources available to you on our website. So you can download related presentations relating to team-based care and value-based payment, for example. And then we'll go into detail on identifying and addressing social needs today. So one of the modules for our toolkit is called Identifying and Addressing Social Needs. That was published around 2019, and it heavily focuses on screening for social risk factors. So some design considerations that you will hear today and also see in that toolkit are questions like who should be screened, by whom, and at what level. For example, at the state level, the managed care plan level, or the primary care team. For what social risk factors, for example, housing or food insecurity? And why are you doing this screening? Toward what goal? States may also consider how screening results will be documented, for example, through the use of Z codes, used to improve care, for example, in the creation of a care plan, or shared across healthcare systems or organizations. For example, a managed care plan sharing the results of a health risk assessment to a primary care provider. And finally, the module focuses on examples of how states are using their managed care contracts to advance this work and pulls out sample RFP language in addition to sample contract language. Next slide. Another resource available for you is this recent blog. And this blog was published just a couple of weeks ago and really reflects on this point of time. And at this time, many states are thinking about how to put health equity front and center in their programs. So reflecting on this, I have 4 considerations for state Medicaid agencies. First of all, be precise with words and goals. Think about what's at the individual level, the community level, upstream, downstream. Also remember that achieving health equity will require much more than addressing unmet needs. For example, to address racial health equity or to achieve racial health equity, we must confront and dismantle systematic racism. So be careful not to conflate social determinants of health and health equity. Second, strive to be more democratic and less technocratic. Often when we confront this subject, we think about how to collect data, how to report data, how to use that data to improve our value-based payment models. But it's important not to forget about the people behind those data sets. Remember that health equity is a process and an outcome. So engage communities and co-design social needs interventions with communities that are impacted, especially communities that have been marginalized. And the last 2 elements, lead when you can, pay for what you want to see, those are related. And that's really focusing on the primary care perspective here. Primary care providers and teams likely contract with many different plans in both the Medicaid space and outside the Medicaid space. So states can consider ways to reduce unnecessary fragmentation as it relates to social care integration. For example, states can identify common tools and resources and identify sustainable funding structures to support whole person care. Now with that, I'm going to turn it over to the lovely Judy Moore-Peterson, and she'll reflect more on some of those levers for state Medicaid agencies.
Thank you so much, Diana. I really appreciate that. Let's just go right ahead to the next slide, please. So we've been working and talking about and considering how to incorporate social risk factors and social determinants of health, or social drivers of health, if you prefer that language, for a number of years within the state of Hawaii. Just a little bit about ourselves. We are nearly 100% managed care, including our long-term supports and services. And so when we think about incorporating social risk factors and social determinants of health into our program, it's largely through and via the health plans or the managed care plans in our area. And as Diana was outlining before, one of the interesting things about this work, and one of the interesting things about us versus CHCS, is how much our goals are really aligned. So ultimately, we're looking at what do we need to do and what can we do as a Medicaid agency to help promote healthy families and healthy communities. And I incorporated this slide because, you know, as we're thinking about it, we're thinking about taking a whole person health perspective, and this is the integration of behavioral health, a whole family approach, which is thinking about not just the individual, but also the connections and the family and the community that's surrounding them. And we have a particular focus on young children and their families. And this is also where we're thinking about investing in primary care as well. And these are all interlinked. And then we also want to think about that family in the context of their community. Addressing health equity and addressing disparities is certainly part of that. And then paying attention to where it is that we live, work, play, and learn. As you can tell from this, it's right in line with exactly what this topic is today. So these social determinants of health or social drivers of health are really key, undergirding this entire concept and our entire strategic initiatives and where it is that we're going. Thank you. Next slide. So as we're thinking, and just click on the next button, please. It's animated. There you go. So as we're thinking about the integration of social care into the delivery of the healthcare system, you know, as Diana was mentioning, you can focus on individuals and you can focus on communities. And how we're starting to our work is actually focused more on the individual level. And then in our phase 2 and phase 3 and ongoing, will be more directed towards taking a more of a community approach. And as you're thinking about on the individual level, you can either, first it's getting in an awareness of what those social risk factors are, and then figuring out, do I change my healthcare to adjust to the needs of that individual, or am I addressing and assisting with the needs of that that individual in addressing whatever social need that they might have. Next slide, please. So to drill down on that concept a little bit more, first, there's gaining an awareness. And this is where you might be doing your screening or trying to figure those aspects about it, of that person. And then if you're making an adjustment, you're using that social risk factor to help change or address clinical decision making. So that's those 3 steps there that are right there. Next slide, please. If you're providing assistance, then what you're doing is thinking about, you're doing your awareness, your screening, and then you're going to be linking those individuals to additional resources to help address their social needs. Next slide, please. So what we are doing in our state is we're addressing 2 things. We're addressing food insecurity and homelessness, and I'll talk a little bit more about that later. But this is an example of, you know, thinking about how these concepts play out for an individual who might be facing food insecurity or homelessness. whether you're providing, first of all, you're doing your screening. I'm going to screen the patients for the person for their food insecurity, letting the clinician know about the results if I'm focusing on that. And then if I'm going to change a clinical perspective based on this, then I would think about, okay, what medications should I change, or how might I need to address this or think through this if I'm prescribing medications that need to be taken with food, or in providing assistance. Well, how can I help them learn where there might be, or how they can enroll in SNAP, where there might be some food banks, et cetera, that they could be able to get some healthy foods. Homelessness is the similar thing. You're screening the person for housing insecurity or houselessness. If again, with the prescribing medications, I might have to think about that. If I have medications that require refrigeration, then how do we adjust that clinical perspective? And then referring patients to either shelters or helping with housing and applying for housing, et cetera. So next slide, please. So within our program, within Hawaii's program, we just recently completed a procurement for, we procured our managed care plans, and we built out and built up a lot having to do with social determinants of health. We incorporated a social determinants of health transformation plan. I know that was a lot. And we have it at two different levels. One is we have one at the statewide level, and we're requiring the health plans to work with us on that statewide level. And that's one that we're taking a leadership role on, where we would be building and reaching out to various different stakeholders, community organizations, legislators, et cetera. And in this process, we're also going to be building, and we are building on already existing efforts within this area. We have an accountable communities of health through the Centers of Medicare and Medicaid Innovation that one of the national plans got here for the state, or for the in Oahu. They're piloting it here. The community health centers have been quite engaged in this, and they've used a tool called PRAPARE. And now a couple of them are also engaged in this accountable communities of health pilot that's going on. And then we also have on deck for the hospitals, we also have a pay for performance effort around social determinants of health as well. So we are also requiring our health plans to develop individualized work plans that should be aligned with the statewide plan. It will be part of their quality assurance and performance improvement plan that all health plans are required to do. And then we'll be asking in that work plan, they need to be thinking about the collection of that data and that information through member level screening. We do have some screening tools already that we've identified to use, and some screening questions, as I noted earlier, we'll be focusing on housing insecurity as well as food insecurity. As part of this building on existing efforts, one of the things that we learned through the Accountable Communities of Health effort is that food insecurity was the #1 social risk factor that our members are facing. So houselessness is, we have the highest per capita of homelessness or houselessness in the nation, or at least we did. And so those two have risen to the top as to why we're going to focus on those two first. So we are working on then the screening tools. We've identified some screening tools and some screening questions that we want them to use, the managed care plans to use. We want them to use the ICD-10 Z codes and promote those. We want to have them increase provider understanding and then incorporate the SDOH strategies, et cetera. And then here's that assistance with their social risk factor. We want them to link the beneficiaries to the SDOH needs. And then developing some closed loop referral systems as well. Next slide. So I already covered this quite a bit here, but this is, we are actually, not only are we going to be focusing on the food insecurity and housing insecurity and homelessness, but we're also going to be starting with a targeted group for members with special healthcare needs. We did that because we wanted to sort of build up on this within the first phase and get some experience and some work in that before we put it out broadly and widely. Again, they have to use the state-approved screening questions. We have them already, and then if they want to deviate, we have to work with them. They are to share that managed care plans are to do the screening, and then they're to share that information with the primary care providers so that they can inform clinical decision-making. And then eventually we want the managed care plans to actually delegate that screening to other care coordination to more closer to the point of care, to the actual primary care provider of that team. Next slide, please. So we, as we've been thinking and talking to primary care providers, some say, hey, we don't have the time and resources to screen for it. And so that's why another reason why we're having the managed care plans sort of work on this and then work on some of the closed loop referral systems, et cetera. But others, particularly with the community health centers, they've already started doing the screening, and this also allows them to continue that role. These screening interventions are focused on addressing that whole person health perspective, and then adjusting the clinical decisions as well as assisting with those social needs for this high need, high cost population, people with very complex health needs, or social needs. Next slide, thank you. So we have lots of things that we have to continue to figure out, because one of the things that we've definitely heard is from the physicians is, hey, we're not social workers. We don't know how to address these social needs. And quite frankly, I don't want the physicians to be spending their time trying to address their social needs. So it's creating those connections with community-based organizations, with that closed loop referral system. How is it that the physicians or the clinics or the clinicians or that team, how do they know that those are being dealt with, et cetera? Part of it will be able to build on some of those pilots that we have, but nonetheless, it's still an issue that is going to require a lot of work and a lot of attention. There's actually a lot of platforms and IT systems and companies and vendors that are emerging that are billing themselves as being able to capture this information, track the health-related social need, loop in the community-based organizations. And so now we're having to think through, we went from like nobody to like many, and then that can lead to some fragmentation and some challenges as well. The closed loop referral systems are a goal. They're only developed for a couple of different areas, and there's still some gaps, et cetera, that we have to definitely work on. The screening questions that we might use in future phases to address other health-related social needs, we still have to work on those, come to agreement, and then adapt and adopt to meet some of Hawaii's needs. Some of it has to do with things that might seem silly, but like the word for bed bugs here is not, or head lice, it's not that, it's like ukus. And so people don't know what that is unless you ask appropriately. Or if you ask about, do you have bugs in your home? Well, everybody has bugs in their home because we live in the tropics. So we are still working through a lot of those kinds of things. And then how do you capture this information, either the coding, EHRs, how do you have the workflow to screen and then refer? Again, it's tied a little bit in with some of those other bullets. And then as Diana was noting, how and when and what health related social needs are you actually going to pay for? we have a waiver in which we can pay for some housing related and tenancy support services, but we don't have waivers in many other areas in which we would also want to pay for those, but we can't because we're the Medicaid agency, and that's just like not going to be feasible and not possible. Also, we actually requested to pay for some additional housing related services, and then and CMS told us no. So knowing that, it's like, well, it is a social related health need, but how do you get that support, and how do you create the expand the community-based organizations, their capacity to be able to address these needs once we start doing the screening, et cetera. Next slide, please. All right, this is, I am not doing this. I just included this as a resource in case people were interested in what we had developed thus far regarding both the screening questions, the procedure codes that we're looking at using, as well as the diagnosis codes when there is a positive screen. So this is that information that is included just for your information. Next slide, please. And if anybody does have questions about anything we covered here, or something that we didn't cover, or I didn't do a drill down on, et cetera, it's myself as well as the two team who I have to thank greatly for helping to put all this together, which is Ranjini Starr and Joy Suarez. So that's it for me. Thank you so much.
Thank you so much for that, Judy. That was a great foray into the life of a state Medicaid agency dealing with these issues and trying to make headway. Next, we have the perspective of a Medicaid managed care organization, essentially trying to advance this work forward and what they're doing in the context of primary care specifically. So Kat FM Latte, take it over.
Great. You can go to the next slide. Thank you, everybody. Thank you so much, Judy. Great to hold space with you in this area. We used to interface in Oregon, so exciting to see her again. So we can go to the next slide. I just wanted to pause, and we at CHPW at Community Health Plan of Washington really are centering whole person care and health equity, and really pause and give thanks to the people whose land I'm on, which is the Coast Salish people, specifically the Duwamish. And the reason why I'm doing this in this setting is that as we think about health-related social supports and social needs, I think it's important to understand the stories of the land that we are on, as those stories can often really drive what individuals need and why they need it. So really encourage others to explore this link right here to understand whose land you are on. Next slide. Who's CHPW? So Community Health Plan of Washington, we were founded in 1992 by community health centers to really be a health plan that could work for community health centers and the individuals that they serve. We find ourselves in that same space, is really rooted in social justice and really wanting to advance those causes as we pursue whole person care. We are also rooted in Washington State. This is the state that we serve, and we really find that really critically important. Really focusing on the whole health of our members and their families and the community, that really spoke to me in Judy's slide, and really thinking about that. And additionally, really just thinking about who our staff and board are local. They're part of the fabric of the community in which we serve. And I think that's really critically important as we are walking through and really engaging with individuals on a day-to-day basis, and both, again, sort of within our staff and our board. Next slide, please. So who do we serve? We really started out within the Medicaid managed care space. We're the only not-for-profit Medicaid managed care plan at this time. But really look at our who we serve as how can we be offering coverage across the care and life continuum. And so really expanded into Medicare Advantage. And also recently, Washington State expanded a public option within the exchange, and Community Health Plan of Washington, Community Health Network of Washington really saw this as an opportunity to partner with the state and continue to consider ways in which we could push towards more affordable coverage for more individuals within the state of Washington. Next slide, please. So this is the slide to sort of start off with. So coming at it from a Medicaid managed care perspective, really thinking through how do we pay for whole person care? How do we drive towards that? And so I wanted to start off with really our dominant model that we have leveraged and built over time and really learned along the way to try to shift it to drive towards the goals that we're seeing again and really centering whole person care and health equity. What I will say is that we've been working on this model with community health centers since 2007. And along that pathway, also wanted to note some of the actions that have happened at the state level that have driven some of this work forward. And thinking about the transition that Washington made to integrated managed care and really bringing integrating whole physical health and behavioral health. And also thinking about really pursuing value-based payment. And so bringing forward expectations within managed care contracts within the state of Washington to align around specific measures, and also have an expectation of the amount of payment and individuals that would be covered by models that really sit, if folks are aware of the Healthcare Payment and Learning Action Network model, from 2C all the way into category 4. So really thinking about some of those pieces that the state has been pushing on, really thinking, okay, so how do we start to grow and build our models to really meet some of those expectations while also meeting the expectations and really partnering with providers in that space. So our dominant model that we have about 77% of our Medicaid members covered within this model is total cost of care model that's inclusive of primary care, hospital, specialty, pharmacy, and behavioral health. It sits in that 3B category as an upside downside shared savings model. We, in that space, tie the performance tie performance and the really benefit of the savings or the reduction of the deficit that has to be paid back to the performance of on 13 quality measures. Those 13 quality measures, as I noted, are really aligned with those measures that the state is putting forward within our contract. And so we do see some evolution of those measures over time as those measures that we have from the state also evolve. We also pull forward CAPS measures, really thinking about that insight as well. And then there's also some specific measures that Washington has developed around penetration of both mental health and substance use disorder to really try to move toward that space of how are we measuring the integration. And then one thing that I will focus on within this conversation in the next couple slides is this idea of how we think about sub-payment methodologies underneath the overarching payment methodology, and how within that space, we're really linking it to strategic initiative programs to really push towards some of our shared goals. But before I go there, just wanting to talk a little bit about, we also partner the model with a lot of access to technical support. We have a population health management platform that integrates claim and clinical data. And we'll talk a little bit about how some of that intersects with some of the work that we've done around identifying social needs in a couple of the next slides. Additionally, we have dedicated practice coaching and support and peer learning opportunities. So really trying to leverage both, we have the practice coaches that are assigned out to specific community health centers across the state so that they really have that point of contact. And then also creating forums for individuals to learn together and share what they're facing, what they're struggling with, and how they might be able to work on that collectively. And then what we've seen with the model is we have seen an increased community investment and partnerships as we look at that sort of overarching space of really tying in the expectation and responsibility of primary care, hospital, specialty, behavioral health, really seeing that drive community partnership, but also after the fact. So as they're starting to see the savings come forward, if they're performing well within the model, seeing increased investment within the community. We've seen housing be built. We've seen expansion of specific clinical services, as well as partnerships that have resulted in the creation of a harm reduction center as well, just to name a few. So we can go on to the next slide. And as I noted, one of the areas that we have tried to build out is thinking about, again, the overarching model being that 3B shared savings space, but underneath it, what are sub-payment methodologies that you could use to really drive forward in key strategies that you want to achieve? And so two that I'm going to focus on, one is around the social determinant of health and social need identification, support, and program development. And then the other one is an equity learning collaborative that we're in the midst of right now. So next slide. So a little while back, we as an organization, again, in thinking about how are we going to, as an organization, and support our providers in addressing the social needs that are coming forward. Again, a lot of alignment with some of the slides that Judy put forward, is that recognition of how do we work towards appropriate identification of what those social needs are. And so we did carry out a survey with our community health centers, and some of the results I have here on the slide. So just, not alignment across both the tool that's being used or even a standard tool that was being used in the first place. That there was identified sort of elevation of need for support around the collection of that data and how to document it within the EHR. And then also thinking through the other component that was brought forward is just not using the identification of social needs to actually design programs that the providers were building out. So potentially designing programs that may not be meeting the needs that individuals were really facing. So through the initiative, we moved to fund specific projects that were brought forward by the community health centers. There's 20 community health centers across the community health network of Washington, and many of them are very diverse and serving different parts of the state. And so sort of elevating what was it that they wanted to focus on. And so here on the slide, we noted some of the projects that came forward that we worked on with the CHCs. And again, in this space, also combined it again with that idea of a learning collaborative and forums together to share. So really thinking about training on workflow integration of assessment tools. We did find that a number of the CHCs were using the PRAPARE tool. Other tools that were noted were the Accountable Health Communities Screening Tool from the CMMI program, Health Leads, and then the Patient Reported Outcomes Quality of Life tool. So those were sort of the common tools that were brought forward. Additionally, looking at strategies for completing patient assessments, both identifying the patient populations initially that should be assessed, but also working through strategies with staff to appropriately ask questions and think about what might be coming forward related to when those questions are asked. How might that be elevating or re-traumatizing individuals? And so ensuring that staff that are asking those questions have some of that support and awareness of how to engage in that space appropriately. Additionally, really building in coding education around Z codes in that space, and then considering how do you expand assessments to all patient populations. So the next couple of slides are just going to show some things that sort of came out of that work. So in looking at the alignment across the PRAPARE tool, really seeing the way in which that could be built to be built in and then move to the identification of the Z codes. And something that I wanted to note as well that really helped us sort of amplify and push this work forward with the community health centers was in 2017, the state of Washington did move forward and incorporating the Z59 code into the risk scoring process. And so that really helped us incentivize the providers in moving towards a space to really ramp up how individuals could bring that code more so into their work. Next slide. The next slides start to shift. So as we were working with our community health centers, we of course were working ourselves around how do we start to build out some of the capacity and bring forward the information that we have. And it was really from a number of different spaces. And so this slide is just a picture snapshot of, from our health risk assessment, what were identified as individuals' unmet social needs at this point in time. And you can see a pretty high level of employment, housing, and transportation coming forward. So that's an HRA data that's coming forward. I think another space, and I'll share this on the next slide, but something else I wanted to note is also engagement and utilization of the enrollment file. And the enrollment file having specific indicators that could also be pulled forward into data. And so thinking through, some individuals indicate that they are unhoused in that enrollment file, and some may use an address that is reflective of a shelter space. And so doing some run-throughs of that enrollment data with some of those specific residencies, having a better indication of understanding when an individual might be unstably housed. Additionally, within the state of Washington, we have a foundational community supports benefit, which is supportive housing and supported employment. And within that space, there's an opportunity to bring forward some of that information as well. So we can go on to the next slide. So this is just also sort of just an image of some of the other data that we've been bringing forward. So we've got Z code data. Jiva is our care management platform, so bringing forward some of that data that's coming out of care planning. And then we also have entered into a relationship with Unitas. As Judy was mentioning, that idea of the closed loop referral opportunity as something that is really beneficial. And so that's something that we've been using as an organization and are working with both providers and community partners to really try to build out the capacity of that network. Next slide. So then this slide is really just to reinforce some of what Diana has shared and some of what Judy brought forward, is just that sort of recognition is that we have to do this in a systemic way, and really thinking about sort of a public health approach to system, community, and then individual. How are we moving that work forward? And so this slide is just to sort of indicate some of that work that we've been doing to have it be mutually reinforcing, but just that recognition that we can churn on a hamster wheel to try to address individual social needs. But if we don't go upstream and think collectively and together about the systems change that we need, then we're not maybe going to get very far. So the next slide, I'm going to move through this, is a program that I wanted to highlight as also Diana called forward, is just that sort of pausing and reflecting that so many of the social needs that we see are really driven by a lack of access to power, money, and resources. And recognizing that much of that access has been determined or the barriers have been created to that because of systemic racism and oppression. And so thinking through the way in which we design programs through an equity lens to address social needs is really critical. And so most recently, we've worked on an initiative to try to bring funding to the CHCs to have them focus on addressing a specific disparity, but really thinking about how they're doing that. And many of those programs have led to programs that are addressing social needs, but wanting to think about what are those processes that need to go into place to build out the design of that program. So as we think about the application process that we moved through for this specific program, we really thought about how are individuals, how the CHC disaggregating data and really looking into the data, both about what's there, but also what's not there. Because we know that we have data that's incomplete, and we know that some of that data is being captured in a way that might not allow people to fully answer the questions about who they are. Considering root cause analysis in the design of those programs. So as we might see, those root cause analyses may actually elevate a lot of social needs that are coming forward that are leading to increased disparities as well. And really inclusion of individuals in the design, development, implementation, and evaluation of the program. So really coming back to that space of engaging those most impacted by the work in the work and how we can do that well. So next slide. Just wanted to give folks a window. We're really in the first year of this program, but now we're looking out to year 2. And I think what we are envisioning is really allowing the CHCs, supporting the CHCs and continuing some of those programs, but really continuing to elevate and center around some of these equity capacities or infrastructure that we've identified as really key, because we just see that we just don't believe that social programs to address social needs can be developed without embedding equity throughout that program development. The next slide is highlights just a couple of the programs that some of the community health centers have been working on underneath this program. And you can see again, sort of specifically some of where they're really using opportunities to address individuals' social needs. And then the last slide that I have is some just reflections and considerations that we've been thinking through in this idea of how do we progress both along moving forward and how we address social needs and social determinants of health or social drivers of health, and thinking about how you embed equity into that work. And so I think just again, that idea of sort of what's that capacity investment that's needed underneath a more advanced payment arrangement as well. And then considering what we're measuring, we oftentimes focus on what we already can measure. So how do we push ourselves a little bit further in that space? And then making sure that we're not only just addressing the social needs, but that we're also thinking about the systems that created those needs to begin with. And really thinking about the power that we have and ensuring that we're really engaging those most impacted in the work. And then just shout out to how we partner with our state Medicaid agencies as well. It'll be key to have that partnership to really move this work forward collectively. And with that, I'll end.
Well, thank you so much to you both for your presentations. And we have a lot of questions from the audience, and a lot of them certainly are reminiscent of things that states have asked in the past in the context of our learning collaboratives. And I want to start on this theme of, potentially duplicating screenings. I know some states worry that perhaps having multiple screenings will overwhelm or re-traumatize enrollees. How do you ensure that patients or members do not receive duplicate or even more screenings? And what is the role of partnerships here? And we can start with Judy.
Thank you. I mean, it's sort of a complicated question in that we are actually, we're more concerned about people not being screened as opposed to receiving duplicate screens. And I think that's part of the reason that we're looking for these broader tools that help you identify and track health-related social needs, is to make sure that, for example, if you have already identified somebody as being houseless, that you're able to track, well, okay, where are you in that process, and that that information is shared amongst the whole care team, not just the managed care plan, but also the primary care provider, the hospital, et cetera, through a shared EHR or through a shared platform. But if you're thinking about, like, for example, if you think when the Accountable Communities of Health pilot that's going on right here, they do ask, they have little iPads for people to answer the screening questions when they first come into the office. So it's not an actual provider who's doing the necessarily who's doing the one-on-one, but it can be done while they're waiting for their appointment. That person will be asked each time they come in to, it's like, would you like to fill in this, and it's voluntary, would you like to fill in these screening questions at the very beginning. So I think that's why it's complicated, because on the one hand, you don't want to, have them asked in the foyer, and then they turn right around and ask again, and then they go to a different provider and they ask again. So you want to make sure that same day you're not asking multiple questions, and that there's an awareness, a general awareness about what those results are. But you also, people's situations change, and so you do want to give the opportunity to for people to update that information. And as part of that screening, they're also being asked, as part of that closed loop referral system, they're also being asked, would you like assistance with these today? And then, yeah, so then it's that is how that closed loop referral system works, and whether they follow up or not.
I think, kind of echoing Judy's point, it is complicated, and it's sort of like, how can we design the system to rule them all, like the ring, for Lord of the Rings. It's just that idea of, we haven't created some of that interoperability that I think would be so beneficial and actually help support some of that. So, what we have tried to do is some of the data that flows through the population health management software that we support our community health centers with can pull forward some of what's coming through in the HRA and some of what's coming through in some of that data that we are collecting. But that is not then meeting the expectation necessarily of the community partner that also might be interfacing with the individual as well. And so I think there's some great things that are being tested out there related to shared care planning across different systems as well. And so I think I'm just really looking forward to seeing how that can come forward.
Thank you so much for that. And here's another question that often comes up in the context of this work. I think there are varying opinions on the use of Z codes. And I think I recall, Kat, you referenced Z codes, and Judy, you also talked about that potential SDOH work plan where a collection of Z codes or reporting of Z codes was an issue. Can you share any lessons learned on provider uptake of billing for Z codes and strategies for increasing the use of those codes?
Since we're still in the planning process, no. So I do know that yeah, it's actually a struggle to get providers to start to use Z codes. They're new, et cetera. But for us, they actually are really key. And we're hoping, we are hoping that there is an expansion and the use of the Z codes, because other ways to collect that information is actually quite limited.
Hey, Judy, can you folks hear me? Can you hear me?
Yes. Well, I
okay.
mean, so.
And Rajni, introduce yourself so everyone knows
Sure.
who you are.
And I apologize, my video won't work, but I'm Ranjani Starr, the Health Analytics Administrator for the MedQuest division. So I just wanted to add a little bit about Z codes, and that is that, and someone else had asked a question about the hospital pay for performance program as well, and sort of how we've done this. But because SDOH data collection is both new as well as so critical to then having that data become part of our administrative data and part of our claims, we have set up the pay for performance program in sort of phases, and currently it's more like a pay for infrastructure measure, where we are essentially supporting the hospitals in setting up their systems, not only to collect the data in their EHR, but also then to have it translated into the appropriate procedure codes and Z codes per sort of our specifications, so that as they implement and they start to use the screeners, that we'll start to see evidence of that, both in terms of the fact that the screening was done through the procedure code and any instances of a positive screen through the Z codes. That we've kind of set up the pay for performance program to build the infrastructure in a way that'll sort of automatically translate to data. So hopefully that helps.
Kat, do you want to add anything from your perspective?
I think the only quick thing is I was shaking my head in agreement of just that idea of, well, one, there's just been a lot of training around this work. So just continuous ongoing training and support and that sort of workflow management. And then how you can create the ease of the system that once something is collected and input, that it feeds other places. So just that slide that I had where it was sort of how you leverage the PRAPARE tool to then inform and have it then code to the Z codes is, I just think that ability to have things to talk to one another so you're not missing then pieces that come through is just really important. But training. And so
Diana, I would also add that because we specified the questions and answers, we were also able to provide the algorithm for, depending upon what answers are provided to these questions, how they should translate to Z code. So Judy kind of presented that crosswalk of here are the questions, here are the answer choices, and then given what answer choices are selected by a member, would that result in a Z code or not for different instances? So we provide a lot of that information up front so that the translation into the Z code is also a pretty standardized process as opposed to sort of a individual or subjective kind of decision.
But we're still at the very beginning stages of this whole thing. So how it's like it's still in the, as Ranjini was noting, we're still in the building of the infrastructure and the capacity phase. But that is as you can tell, Ranjini and Joy, who are part of my team, they're happy to share additional information down into nitty-gritty details that we have, noting that we still have a lot more to do and a lot more work to do in this area.
Kat, you noted the need for training, and I'm wondering if you've taken any steps to encourage a trauma-informed approach or other training techniques for providers doing the screening.
that's something that I'd have to pull forward the training approaches. It's something that we've done overall with respect to the work with our providers as well as with our staff. And I think it's the recognition, so it's been brought forward. But related to specifically in the training and work plans to build out the identification and use of tools for social needs and social supports, I would have to directly get back to you. But in a broad sense, we have really been trying to promote those topics within overall provider training as well as training with our organization, so that that's embedded as they may be engaging in these in this specific work.
Well, I looked down and the time really flew by. I just want to thank you, say a thank you to both of our panelists today. We really appreciate your time and expertise. The slides and a recording from today's event will be posted on chcs.org. And in addition, if you attended this webinar, we'll send you an email with that information as well. But thank you so much for joining us today. And do keep in touch. Have a good one.
Aloha.